Good afternoon, everybody. I'm Jolanta Kunikowska. So I will try to show you why we are doing your work, because exactly I'm using what we are doing. And we're starting about the theranostics, as you probably know, you have this some kind of the background, that we have the diagnosis and therapy from the board, and we have your pharmaceuticals, and with this isotope and target. And I always telling to my colleagues to the clinical ecologists, targets is like for us the key to the door to deliver the isotopes, which is exactly the working point. Of course, it will be different for the diagnosis, it will be different for the therapy, but this is our house. This is something that we need, and without this, I can't, provide my entire medicine department without the help of the radiopharmacist pharmacist. And if we look for the isotopes and the target, what is important? A little different with the story from the diagnostic part and this one for the therapy. If we want to do the diagnosis, it's important the half-life will be not too short, but the shorten that is as short as possible for the diagnosis, but to not to deliver somehow so much the energy to the patient because I don't want to have the biological effect on it. And opposite, the story is for the therapy part. Because for the therapy part, I need the radiopharmaceutical the longer half-life and with the high energy to deliver exactly the energy to the tumor because I want to destroy the energy. So the range, emission profile, and this tumor distribution, this is in this one thing. And for the target, and the most important is pharmacokinetics and what is the role or the expression. Because as you know, that the majority of our patients will be oncological patient, and this expression is usually by the kidney, and sometimes we have the patient with all the areas. So that will be the something that we could be the some kind of mutation, internalization or not, as well as what is the cancer and tumor specific. This is, the something that we need to have in our mind. And if you look for the isotopes, which is possible, and the table on the right things that you have that was the record for the European Commission. And as you see, that majority of this isotopes is expecting that will be the growing. The same is for the SPECT imaging, the scintigraphy, as well for the therapy for the tissue. As you see, that is that is expected. Of course, in this report, it was not so much about these new isotopes, because this is for the research that was writing down for this what is existing on this label. But you see that even in this report that it was actinium, it was rhenium, holmium, copper, and lead that you had this in the morning session, which was mentioned. And of course, for me, it's important to have the more alpha emitters. Why? You exactly know what is the difference between the alpha and beta, but for the clinical point of view, with the beta emitters, you have this wider range, so they have the more side effects. And I have this cytoxically by the oxygen. I have the alpha. I have, this high range, high energy in the shorter range, so limited, the side effect. And I have exactly destroying the DNA brain, so it is independent of oxygenation. So if I have the hypoxia, the tumors, I still could use the alpha emitters, which is, the tumors could be resistance for the beta emitters. And what we could use for the targets, but I mean that it could be lots of the different things for this, but for one thing for the clinical point of view, if you take into consideration the big, these targets, that like antibodies, before we do the diagnostic part, we need the longer isotopes for the diagnostic part because we have a lot of the background for this. So please always remember about this pharmacokinetics. And you have to think about the theranostics story. And exactly the theranostics story starts in Poland with, that's Maria Skłodowska, because she discovered for us exactly the Poland earlier interview. And if you have your free times, please visit, the museum of Maria Skłodowska. We liked it very much in the past because it was the Poland interview. Unfortunately, now it's very nice, it's rebuilt, but this is the building that is now, which is on the old town. So please find the time and visit this. And what we know Why this is our favorite story? Because iodine is uptaken by this iodine sodium pump. So exactly we're going for the molecular imaging, and we could use the same isotopes for the diagnosis and for the therapy. And you know that there's theranostic versus the IBI will be iodine 23 and some iodine 131. And even during this solar cards area, you see they did the full, the story with, this dosimetry study. So we have a lot of the knowledge even for this last. And this modern kind of the theranostic is started in 1994. It started in Netherlands with the treating of the European tumors. And we know that European tumors, this kinds of the cancer which could be disseminated in the body. We have the problem with treating this patient because usually this is in the late stage. And unfortunately, chemotherapy is not working because the response rate of the chemotherapy in this type of tumor is 20-50%. So it is not the good option for the treatment. But these tumors, we know that they express the same kind of receptors. And you know that the first story is about the somatostatin receptors expression. And we could use for the diagnosis of the patient with the gamma probe, we could even to catch this single, the metastasis. And in disseminated disease, we could use for the therapy. And you see this the first example, even with the injury that time, that really because the first agent it was this they used for it with the injury for the diagnostic part. 1994. That's you see that we got more than 30 years experience with the European tumors. And we as a clinician, we know that this is, the tumors that we need a lot of the knowledge to good to treat the patient. We know that we need histopathology, we need the biomarkers, and of course we need the conventional radiology, but it's when we need the functional imaging. But the future is new markers and genetics. And we have, this knowledge about the somatostatin receptors, we know who will be responsible better. And if we have, this kind, the expression, in the past with the somatostatin receptor, it was framing scale, now we could use for the PET scanners with calculation of CUB max. We know who responds will be better. Even more, we know that this kind of the tumors could be more aggressive during the years of existence. So the tumors which I investigation I diagnosed today, and this kind of the same patient will come to me in next 2 years is totally different behavior for these tumors. And this is something that you have to understand this the tumor behaviors is changing over this, the time period. And this is the reason that we need FDG. Everybody knows in this, knows FDG. This is our common tracer, but exactly in neurocrine tumors, they give us this aggressiveness of the tumors. Because in neurocrine tumors, from the beginning, they overexpress of somatostatin receptors, but don't they have the uptake of FDG? Because are very, latent tumors, so they are not aggressive for this keen high behavior. But over the years, they lose those somatostatin receptors according to more you accelerate signals. And this FDG gives us exactly prognostic factors, how this patient will respond. So as you see that these 30 years give us a lot of the things. What is the treatment response? If you want to ask what the therapy is better, we need some calculation. This is progression to survival. So how long the patient is living without the progression and overall survival. And if you look, because you know that we could treat with if deficit was issue, that it was rotation, we use the tandem therapy, but nevertheless, the isotopes that we use for the somatostatin receptor, you have PFS about 30 months. On the other hand, you have your everolimus and sunitinib. This is the new chemotherapy drugs. When you have the PFS 11 months, I would ask you, if you have your family and you have the drugs with PFS 11 versus 20, which drugs will you be using? With this shorter or longer? Longer, of course. And that was something that is easy for us to understand. But we are not in the desert islands. We have to talk with our clinician. And we tell them that we have the nice experience. You see, we have the good PFF. We have the good experience. We have the limited side effects. But unfortunately, oncology told us, so sorry, you don't have the randomized data. You really don't know that your therapy is really working. So this is something that we need to take into consideration, that to talk with the clinician, especially with the oncology work, we need the big data and we need the randomized studies. And as you know, for the European tumors, we will have to wait 25 years. 25 years for the first randomized study. It was letter one. It was the patient for the European tumors grade 1 and grade 2. And clearly, you see, that is the Kaplan-Meier curve. This is something that we once again combine the both therapy, and you see that for the tissue data, that is much better survival than for this cold somatostatin analogs. And during this letter one, it was when it's published, it was not reached, but after that, it was calculation, it was 28. So maybe the same that we did for this not randomized trials. Even more, that year it was released letter two trials. This is for more aggressive tumors because letter one it was for this grade 1 and grade 2. Now we have grade 2 and grade 3, so more aggressive tumors. And in the both, you see the clearly visible the difference between the therapy. So now we know that it's working. And this, believe me, after the letter one, it was the big discussion to change the guidelines. And it is have to wait for the third change on the guidelines and what is there. And if not for the somatostatin analogs, we have continuous involved in this class. We have this, of course, the PET. As well, now we have the antagonists of the receptor, as well as we have this alpha emitters. And what we know, this antagonist, we know that they have no internalization, but very high stable with lots of the numbers of the sites. So this delivered doses is better. So we have to, work with this others with the tracer. But once again, we took the story of this and we need to talk with the clinician. And we have very nice work. But that's early treatment as well European tumors. It was the mainly discussion with this endocrinologist for a little understand what is isotopes. But if you're going for the oncology is prepared for the chemotherapy. So they have drugs, which is lying on the shelf. They take it, they calculate, how months should be the patient. But it is a little different story for us. For us, radioactive compounds is exactly the drugs, our radiopharmaceuticals, but this is not like the normal drugs. We are playing the games with the time. And it is exactly used for the patient. It can be used for the other patient. It is not waiting for the patient. That's exactly the order for our patient. And with this multidisciplinarity, we talk with the clinician, of course, we have the image, we have the oncologist. We have to talk with the surgeon because sometimes we are using it for radio guidance, surgery. So this is a really important part as well as for the radiation therapy specialists. So we have to deal with them with the same language and the same word to understand what is exactly the radiologic therapy. And even, inside the nuclear medicine, we have the multidisciplinarity. Most of you are radiochemists dealing with the chemistry. So you know about the supply and the production, about the quality control. How is the big problem? We order something, but the quality control, it was failed, and we couldn't treat the patient because we don't have the isotopes. And they have to understand that it's not our fault. This is like in your kitchen. You do something, and sometimes it's okay. Sometimes with the same ingredients, it's radiation safety. Please believe me, they completely don't understand what is radiation safety because the radiation is not visible. The patient is not like the lighting, and we go into the department, and on the one part they could be afraid about everything. On the other part, because it is not visible, okay, it's nothing. So this waste management, dosimetry, and this you should be discussed. And of course, we have this new, not nuclear medicine compound, and this our colleagues from the clinician, that they need to understand what is the way of the patient and how to do it, and understand what is exactly going on in our department. So you see that it's not so easy for them because they are not prepared for this kind of a discussion. And hopefully we're doing the better story with the PSMA. As you know, the PSMA, the story started in Germany, and it was in 2014. That was the first, for the diagnosis as well as for the therapy. This is well known by everybody. I really always stress that if I have the diagnostic, I showing this. It is the image of the man from the SNMMI from 2018. And you see in the patient who progressed with this after this unconventional treatment, which is available, still we could have very nice response. So we have the good target, we have the good therapy. And with this, we know exactly when it was, the previous for the neuropain tumors, but for the PSMA is the same. We know exactly who should be the treated. If we have, not the good expression, if we have disseminated disease, but it's not the good solution, but if we have the high expression, we know that this patient will be the good response. And the story with the PSMA is much better than for the Lutathera, as you know that it was not 20 for the first clinical, but there's the first PET imaging as well the therapy 2014, and the approval is just in 2021. So you see that it was not 25 years after waiting for this. So we took this lesson and we did it great jobs. And with the PSMA, because the prostate is this the second common of this of the cancer. So we had a lot of the randomized trial. First, it was therapy, and you could see that if we compare the lutetium PSMA with the chemotherapy, we have a one small response for the PSMA. And that was the registration trial in the vision trials. As you see that we have nearly 40% reduction of the death, 60% reduction of the population. So we exactly have the drug who is working. And you see that 1941 is the was iodine. The second one, it was 1994, that was lutetium date, and now 2021, we got this registration of the first our theranostic drug. Just recently, that year, it was the new trials showing us. This is, PSMA addition, because you know that in the vision and the rest, it was used for the last line of the drug. As you know, that is exactly like always the same. But here you see we have in hormone sensitive. So we move, it's much de-emphasized this PSMA, and you could see exactly that we have this better number with the p-value. It's very nice that we have the better response for tissue with added to standard treatment, that's with RP and the ADT, versus this ADT with the RP, that means the standard treatment. So probably we should not do use in this last line, like it was this, then we go before the chemotherapy or maybe hormone sensitive. And the very nice trials, which is now ongoing in the Australia, using the high risk patient, lutetium PSMA will form before the surgery. Because we don't see the metastasis, micrometastasis, this resolution of hormonal metastasis. And lutectomy is 2 doses of the lutetium PSMA before the treating for the surgery. So this result will be have to wait longer time, because as you know, that will be quite longer this time of observation needed. But that would be really important what we could do maybe in the very early phase. As I told you, we took the lesson, and in guidelines by European Association of Urology as well, it was in the Vienna. This therapy, exactly in 2021, it was in the guidelines. So just after this, this randomized trial that was released, urologists put that we have to offer lutetium PSMA in the patient with this because that time it was with this MCRPC, also with vaccination patient. With the strong data that you see, that we're very, very fast way to be in the guidelines. So this is the lesson. We need randomized trials. So please, if you are trying to do your own work, please remember that next time it should be the discussion with the clinician and oncologist that we will do. And one of the nice examples was the drugs that we know, because this is with tissue database. We have registered. It's now just the year just started with human study with the same drug that we know for the neurocrine tumors, but different indication. This is the indication with the myeloma, which could express somatostatin receptor 2 the same. And you see here, this is the myeloma, and that was the patient treating with this agent with very nice response. So waiting for this results of these trials. And a little to show you what is in the pipeline, and this is your carbonic anhydrase 9. You know about this. But I just came back, I was last week for this the meeting with the urologist, and they love it. Because, they have the kidney tumor, and they don't know that it should be wait and watch, or they should be operated because it's a disease. And this how we're going to integrate with this economy labor, erotic give the response. And even more further, we now have the data that the tissue therapeutic part for this. After the second phase trial, we know that we have disease control about 74%. Very nice. The next, the therapy approach for this kind of the treatment. And so please believe me, in this FCT, we didn't have offer them something only for the diagnosis and for the therapy nuclear vaccine. It was quite difficult for a judge with this. Happy. Fibroblast activator inhibitors. We know that this tumors, and we have a lot of the data on this. And if you look for this trials, you could find several ongoing trials, mainly with tissue and tissue, and you see that this is in different indication in pancreas, ovarian cancer. So the next will be ongoing. And of course, we have other potential targets. You know that you are working on the clinical part of this. We have this CC3, GLP1, UPAR, we have CR6, CR4, we have the gene therapy even. So that will be for sure that will be the more distributed trials. And if you look for this is labeled with different isotopes. So this is not only the tissue. It is the terbium, it is actinium, of course, that we're talking about as well. So this is your work to be ready for us to the clinical trials for our patients. We have the nice new couples, and these new couples are coming because you know that's have it. Of course, Calvio, which is really interesting, and for everyone, copper with this longer half-life, maybe for the dosimetry before. That's why the terbium, because in the terbium we have all the range of the radiation, we have the alpha, we have the beta, and we have this gamma emission. So this is the next couple that for sure that we don't go in. And this is the slide that you see what is this current the landscape. And if you look for this landscape and what is going on the diagnostic and how many companies working for this, you see that this is the big piece of the cake now. It is not, like it was in the past, only the iodine or small water like neurocrine tumors that we will go. So please remember that behind the scene, we have to think about this isotope reproduction variability that you talk about this. This is the PRISMAP. And legislation and regulation that was on the morning session. And for me, important is reimbursement. Even I took, a very good drug like we do now, we have the Provito in Poland, we don't have the reimbursement. So I can offer this patient. So see that this is something that is really important. And maybe we should think out of our desert islands, take out our comfort zone. And if you want to have the impact beyond oncology, please believe me, we need to randomize trials. We need to take the discussion with multidisciplinarity, and we need to talk with them with the same language and the same word to understand each other. And so with them, I want to thank you, and I hope that you will be working for the better of the patient perspective.